So, elimination, let's talk about it because there has to be a base of what you learn, a platform on elimination, so that we can grow and talk about different disease processes and other things that take place when we're dealing with the kidneys or the renal system, the genitourinary, or the GI, the gastrointestinal system. And that's how we talk about elimination. Let's get started. So, of course, when we talk about elimination, what are we talking about? We're talking about how our body processes everything that it does and takes it and gets rid of those toxins. It's the trash. It takes all of the stuff we don't need and we need to get rid of it. We either do it through urine or we do it through feces, fecal matter. So it's something that we all do, and I love to tell this to folks is no matter what, we all urinate and we all have bowel movements, don't we? There's other words we can use, but we won't because we're professionals. Anyway, so these are some goals. I will not read them to you, but they're here. But we definitely want the appropriate nursing and collaborative interventions to optimize elimination. And that is something that we've got to think about as we're talking about this. What are we going to do as the nurse? So when we talk about the concept of elimination, we do conceptually based teaching here in the state that I teach in. And so the concept out of Giddens' book in 2017 is the excretion of body waste from the kidneys and intestines and their alterations. So that's the concept of elimination. And so here's two pictures that look great. The picture over here with the body right over here, if you can see my little pointer, it's the actual kidneys, and we're looking at the bladder, that whole genitourinary system. And then over here to the right, it's the GI or the intestinal piece that deals with the excretion of fecal matter, the metabolism, the process of breaking down foods and stuff, and then the getting rid of the waste through that GI tract. So you can see it starts with the mouth, and we have to think about these things because it's these things that we take in that we gather and do as we process to get rid of. So things can happen. I mean, we can have many different issues along the way, and we'll talk about all that stuff. So like I said, when we're looking at elimination, we're talking about the trash truck of our body. It's going to gather and get rid of. We need to. If we hold on to it, we can become toxic, and that can become detrimental to us physically for our health. So let's look at it. Bowel elimination, what is it? It's the passage and dispelling of stool through the intestinal tract by means of intestinal smooth muscle contractions. So we have smooth muscles that contract all the way down. It works itself as it's absorbing, right, nutrients and water out of what all's in that GI tract. It's going to do that till it gets to the bottom, and then it's time for us to go to the restroom and have an actual bowel movement. Urinary elimination is the passage of urine out of the urinary tract through the urinary sphincter and urethra. So as we are thinking about it, we'll go through fluid and electrolytes this next week for my students, and we'll start to talk about what happens in the kidneys and how it works, because we're always trying to maintain homeostasis. And because of that, we've got to process everything, gather it up, what we don't need, and get rid of it, because if we keep a hold of it, we're going to cause more harm than good. So that is truly the definitions of bowel elimination and urinary elimination. So what should you know? Well, these are some terms that you really need to know. Defecation is the discharge of feces from the body. We're having a bowel movement. That's what we're doing. Micturition is the act of urinating. So you can say micturate. Voiding, discharge or drain away, is actually the definition of that, but we use it for urinating. So if you need a void or the person is voiding, that's the term we can use. Continence, the ability to control movements of the bowel and bladder. So if a person is continent, they can control their bowel and bladder. But if they're incontinent, they have lack of voluntary control over urination, defecation. So they can have problems, accidents, urinate or wet themselves, or defecate or have a bowel movement without control on themselves. Retention, difficulty urinating and completely emptying the bladder. So you go, but you're not getting rid of all of it. And because of that, we're retaining. And then what can happen? Think about this. If we hold on to urine, if we're having to urinate and we just do a little bit, but X amount stays in the bladder, then what happens is we can start to grow bacteria and different things inside of the bladder, which causes us to have bladder infections. And we don't want that. That can cause us a lot of issues and problems. Now, we've all taken anatomy and physiology. For me, it's been 100 million years ago, I won't lie. But for you guys, probably recent since you're in school. But this is just a picture over here to the right showing you the actual breakdown of the ascending colon, the whole colon, the left colic, splenic flexure, descending colon, sigmoid colon, rectum, and anal cavity. Kind of understanding the anatomy is a good thing. There's some terms over here for anatomy. Just review those. You're never going to go wrong understanding the anatomy, because understanding that will kind of help you understand about ostomies, about what's going on and we're having issues, and why we see what we see. So just review yours. I'm not going to reteach anatomy and physiology. Someone already taught you, and I'm sure they were awesome. And so go back, take a quick review. So back to the anatomy physiology. On the flip side, we need to take a look at the urinary piece. So we have the bladder, the urethra, the internal sphincter, and external sphincter. And these all play a role, in what happens when we're having to void. This is a picture I actually found, and even though it's so super simple, I love the look of it. Kidneys, ureters to the kidneys, the bladder, and then the urethra. And so it's always kind of interesting to know. Go back and review, though. Look at where your internal and external sphincter are, because they are going to make you kind of understand what happens if damage is done or anything like that with that system. So go back, review both anatomies of bowel elimination and the lower colon and rectum, anus, that whole piece, and then the urinary elimination piece right here. So I love this visual here. It's variations of the elimination problems. And so what we've got is we've got the concept of elimination in the very center of this. And then off to one side we have renal, the other side we have the intestinal tract. With that, if you notice it comes off, we have retention. And I know on the slide back, I didn't mention retention of the bowel or retention of the intestinal piece. And that is a problem. If we hold on to fecal matter, if we don't have a bowel movement, we can become constipated. It will stay in there and dry up more and all of these issues. If we don't drink enough, we can be constipated, just different things. But I love how the arrows go. For my students, we'll start out very, very basic with trying to get a concept, get nursing interventions and different signs and symptoms and things, and then prioritize our nursing interventions. So one of the things looking at this is great. But if you notice that the retention, bowel or bladder, it all comes down to discomfort. They both point to discomfort. Elimination, it's going back and forth to control. Can we control it or not? And then we have continence and incontinence. Are we incontinent or continent? And those are the things. You've learned those terms, or at least in the slide prior, you need to learn those terms. And then, but this picture's great. It's just a great visual, and I enjoy it. So let's talk about incontinence. Urinary incontinence. So we have stress incontinence. It's sudden involuntary loss of urine due to increased intra-abdominal pressure. So when that happens, you think about it is sudden you scream or you sneeze or you laugh, and then all of a sudden you have this added pressure, and so you have some incontinence. Urge incontinence, sudden compelling urge to go. You're running to go to the bathroom. Gotta go, right? And it results in an involuntary leakage. You can't control it. You just start to kind of leak just barely, but it's coming. overactive bladder, a problem with bladder function that causes sudden need to urinate. If all of a sudden you've gone to the restroom 15 minutes later, if you have an overactive bladder, you can have the need to go again. And if you don't go, you can actually have some incontinence, some leakage if you're not careful. But that overactive bladder can just take control of your life. That's why they have a medication out there that helps with that. And so all of these things can cause issues and problems. So we want to address them and make it better for our patient. So looking at the different types of incontinence, we look at the this picture speaks volumes. So if you look over here to the far left, we have this giant looking balloon with the arrows pointing outward. That is an overfilled or an overflow bladder. It is so full, it's bulging. This can be caused by urethral blockage and bladders unable to empty properly. Then we look at stress incontinence. We have a relaxed pelvic floor, increased abdominal pressure. What causes a relaxed pelvic floor? Well, for women, it's due to childbearing, different things like that. Aging process will help relax that out too. It's not as strong. And then if we get an increased abdominal pressure from laughing, coughing, crying, whatever, then it can cause us to have a little bit of leakage. And then we have this urge incontinence. That's a bladder oversensitivity from infection or neurological disorders. So whatever's happening, it's stimulating the bladder and it's making it go, gotta go, gotta go. And then we have this, we can't go, or we're in the process of trying to get there, and we will start to leak, and we have this incontinence. So these things are very interesting to look at, but I think the pictures speak volumes, right? So we don't have pictures for this, but these are some other urinary incontinence types. Functional incontinence is you cannot make it to the toilet in time to urinate. You've fallen and broken your leg. You can't walk across and up the stairs to get to the bathroom, so you're going to end up urinating on yourself. We see it with the elderly. They have a lot of other issues going on, but they can definitely have it if they're unable. They have to use a walker or they're slow. This can cause functional incontinence. Mixed incontinence is involuntary leakage of urine associated with urgency and with exertion, effort, sneezing, and coughing. So we have that abdominal pressure on top of, it's a two thing, it's a twofer, and that's because it's mixed incontinence. So we already have involuntary leakage due to urgency, gotta go, but then on top of it, anything else can cause us to have pressure when we have that exertion, effort, sneezing, or coughing that causes us to have a mixed incontinence leakage. Transient incontinence is urine leakage that is caused by a temporary or transient situation, such as an infection or a new medicine. So you might not have problems with stress incontinence, with urgency, any of that. But let's just say you've got a UTI and it's an infection, right? It's a bladder infection. So we have this urinary tract infection and you all of a sudden can't make it to the bathroom, or you have a little bit of incontinence. It could be due to the infection. And so once the infection is taken care of, you shouldn't have this incontinence anymore. If the medicine is new and it's something that's causing it, it needs to be addressed with your physician. And then if you still need to take the medication, then maybe different times of the day, different things like that. But transient incontinence is something that if I stop taking the medicine, I should be okay also. But it isn't a go to a patient to say stop taking their medicine. They need to take it, but we also need to know what's going on, that it could cause urinary incontinence. Some medicines do. So if we have loss of control, if we urinate on ourselves, if we defecate on ourselves, that's the involuntary release of urine or feces, it can lead to different things. And we talked about this today. If we're doing tube feeding right now, right? So if you start to have tube feeding, it can cause you to have loose bowels. It's a liquid going in and it just causes us to have loose bowels. So what is our concern about someone that defecates on themselves or urinates on themselves? Think about it. They're going to stay wet. They're going to not be able to they're going to lay with pressure in that area, warmth in that area, so they can have skin breakdown. It's a biggie. So if we have loss of control or incontinence, what do you think we need to do for those folks that are bedridden or have to wear a Depends or something like that? We need to put on a barrier cream to protect that skin. We need to have them move side to side, get up, support, get blood flow to those areas so we don't lose blood flow by pressure and then having skin breakdown. We don't want that. If you're moist all the time with urine down there, if you're incontinent, you can have yeast infections. You can have irritation, raw, painful skin. So it's so important that we protect the skin with a barrier cream to prevent these things from happening. Change in daily activities. Changes. Now, this is the deal. Nowadays, thank goodness, we have companies that have made Depends or we call them adult diapers, but we don't like to. I call them Depends, even though I know that's a brand name, but I don't really want somebody to say I'm in a diaper. It would really hurt my feelings because I'm not that bad off, and no. So anyway, but what can we do for activities? If I was on the trampoline team and I'm having urinary incontinence or fecal incontinence, guess what? I think my daily activity of jumping up and down on that trampoline is not going to happen. It's going to have to change. That activity is probably going to have to go away, and I'm going to do something that doesn't cause pressure or doesn't cause any kind of pounding or anything that can create incontinence or cause me to have more incontinence. It can also change in social relationships, right? You don't want to be out with your friends and then all of a sudden wet your pants. It can be embarrassing. There's a lot of psychosocial issues that come with this. People feel like, they're out of control. It's that loss of control, that psychosocial. And with that, many things, depression, different things, the discomfort of smell. I'm afraid people can smell me or different things like that. So one great thing is that we can teach our patients and families and friends that have these issues that we can wear things. There are things to clean yourself up with where you can go out and be engaged in social activity. Sad kind of story, but I'll share it. My dad had a massive stroke. He passed away from it. It's been years now. But my mother, he had lost all control of urine and feces, fecal matter. And my mother was so embarrassed by that she never would take him places. Like we always would go to the beach in the summer and we wanted him to come and stuff. And Mom said, no, we can't because, he'll mess in his diaper. She called it a diaper. And so it was just so demoralizing for my father and sad. And so it really can alter, and not only the loved one, but others, loved ones that are involved. So it's things to kind of think to. But loss of control can be a problem, and that's something that needs to be addressed. So if you have urinary incontinence, you need to think of the psychosocial part of loss of control. What all does it affect? So the urinary retention. Cause: external sphincter does not open for release of urine or blockage of the urethra. Those are the causes of urinary retention. What is retention? It's holding that urine up in there, right? It won't let it out. It leads to increased urine volume and bladder distension. Our bladders are made to hold X amount of urine, period. Now, can we hold quite a bit? Sure. And we get nursing bladders because we'll work and work and work and have to go to the bathroom. We just hold it again until we can't hold it anymore. The bladder will stretch and stretch just like a giant balloon, but eventually it can't stretch anymore. So we have to be very, very careful with this. We can have backflow to the upper urinary tract, dilation of the ureters and renal pelvis, and pyelonephritis and renal atrophies. These lead to increased urine volume and bladder distension, these problems. So if I have a bladder and the sphincter won't open, or I have a blockage in the urethra, it's going to keep urine. It's going to back up. It's going to back up. Remember that picture? up out of the bladder through the ureters and back up into the kidney. If it gets into the kidney, it can literally drown the kidney. It can kill the kidney, and we don't want that. You will shut your renal system down. So that's why it's so important that things move. The other thing is that it can hold so much that we start to have the pain and discomfort in this is huge. You're really uncomfortable. You have to go. Have you ever held your urine for a long period of time? You have to go. The exit goes by. You have to go. The exit goes by. You have to go. The exit goes. By the third or fourth exit, and you're still having to go, it's getting uncomfortable. It hurts. Well, same for these folks. It's very, very uncomfortable, and something's got to give. We've got to do something, or the damage will not be able to be reversed or fixed. So the other thing our worry is a bladder can rupture, just so you know. So if we don't empty a bladder after a period of time, the bladder can actually rupture too. And if that's the case, party's over. You're not going to die, but you're not going to have a bladder, and that's going to be bad news. So let's talk about bowels. Let's talk about bowels, baby. I entertain myself. Anyway, cause, ignoring the urge to go. If you have to go, or you have decreased peristalsis. Peristalsis is a word you should know. It is the actual movement of that smooth muscle in the intestinal tract, and it's just that rippling motion all the way down. It's peristalsis, and we have to have it. If we have decreased peristalsis, and I've got a picture to show you, where the fecal matter is not going to move. All of that food and stuff that's been digesting is moving very, very slowly. And when you move slowly, or you have an urge to go and you hold it, the intestinal tract is absorbing volume and fluid out of that. That's what they want. That's what it wants. It wants to get everything it can. Everything we need needs to come out of there. But once it sits up in there for a while, it'll just take out all the volume, the fluid, and if it does, it becomes dry and hardens. And when that happens, it's hard to move it. So we have decreased peristalsis, we're holding onto this stuff, and the intestinal tract is just sucking every bit of moisture and everything else out of it, and it becomes a dry, hardened, big block. And then you're trying to get rid of it, and that's very difficult. It can be painful, uncomfortable. You feel bloated, you feel nauseated. There's a lot of things with constipation. Then if we don't get rid of it, we'll become impacted. It's just massive stool that just sits up in there. Let me go ahead and share the next slide. So when you're looking at this, you can see that this is the anatomy. This is a great picture. So this right here, if you can see my little black dot, I'm flicking it around. I'm over to the left picture that says normal. This is our actual rectum. So this is that intestinal piece. So the stool should be coming down, and it's going to come out that way. We're going to defecate. Then if you look over here, the big pink with the, or red with the pink around, that's your bladder. And so that sits here. Now for females, this is our uterus. So I want you to look at this because this is important, so it'll help you understand what's going on. And then we have the vagina here, of course, that goes up to the uterus there. So when we're looking at all of this, when we come over here to impacted, the fecal mass, this black piece is fecal matter. It's a fecal mass. And I want you to look at this anatomy to the left. See how everything kind of lines and comes out. The uterus, the vagina comes out, the rectum comes out through there. So, or the colon, and then it comes down, and we actually defecate through that way. Now, when you look up here, if we have a fecal mass, if we're impacted, it's just fecal material, and it's the bowel is stretchy. So what happens is the more that comes, it'll just stretch a little bit bigger, stretch a little bit bigger, and you can see how much this is stretched and filled with fecal matter. Because of that, it will not move. There's nothing moving. It's just piling up, piling up, piling up, right? In the process of that, it's obstructing urinary flow. Look at what it does. It comes across and it's then going to start to push on our urethra and bladder. We're having issues there because of the impaction. Everything's very close down there, believe it or not, it is. And so we have to be very careful. So not only are we not getting rid of fecal matter, we're also now going to have to start having issues with going to the restroom if we're impacted. So that's why it's so important. How do we get rid of an impaction? Manually. That's where we go in and we'll disimpact a patient manually with our finger, gloves on. So this one's an interesting one. Let's take a look at it. So it's now risk factors of populations that are at great risk. We're all at risk. I don't care what age you are, what race you are, what gender, we're all at risk, potentially at risk for bowel and urinary elimination issues. So there's different things that can happen, diseases that can cause it, but there's 3 populations that are at greatest risk, and that is children, pregnant women, and older adults. So let's look at it. So for children, one of the things, as we break them down, you have infants and toddlers, and then, children, adolescents, and it goes on. There's different things that happen developmentally. Our GI tract has to continue to develop as we're infants till we get to a certain age. And then we should be having regular stools, and then we'll grow in sphincters and have control, cognitive stuff. So we have a lot of issues there that can happen. The other thing is diet. So children, what do they eat? They're not eating high fiber foods, all the good stuff that keep bowels moving. They're not drinking lots of water, are they? So one of the things that we need to do is definitely take a look at children at the age that they are and what they can have, and make sure they're nutritionally get what they need to keep their bowels and urinary tract in line and moving properly. Pregnant women. Why pregnant women? Well, one of the things that happens with pregnant women is the hormone progesterone can cause the gut to work less. So that can be a part of it. And because of that, it decreases peristalsis due to progesterone levels. And when it does that, we hold on to stool. It causes constipation. If we don't fix it, we can become impacted if we're not careful. The other thing with pregnant women, as the baby grows, and we saw that picture where you had the bladder, and then you had actually the vagina and the whole uterus, and then you had the large intestine coming down and going out the rectum there, so anus and rectum. So if that's the case, if we're pregnant and this baby gets so big and pushing on all this, is it going to create issue urinary wise? Yes. Bowel wise, could, definitely. We saw what can happen, and then the progesterone can help with the bowel problems. Older adults, what happens as we age? The number one thing that happens as we age is everything pretty much slows down or starts to decrease. And if that's the case, peristalsis can take place. We can have urinary stasis if we're not careful. The other thing is in the brain, as we age, for drinking, we stop wanting water. There's a thing that clicks off in the brain and it says, no, I'm not really thirsty. So we decrease water and live in a dehydrated state as we age. Because of that, it can cause UTIs. We can have these issues, constipation, impactions, different things like that. Then let's add the medicinal piece in here. So if we're talking about medicines, the main thing pregnant women take are vitamins with iron. Iron is a constipator. It's going to cause constipation. So that can be a problem for a lot of women too if they're taking that vitamin, prenatal vitamin with iron. It can cause it. So they need to be drinking more and eating more high fiber to keep things moving. The adults, older adults, they can take pain medicines. They can take different things that slow peristalsis, and because of that, cause constipation. So there's things to look at. Just start to think. Think about when you're sitting there listening to this, then just stop for a minute and think, what else could be a factor? Let me think about this. And go ahead. You've learned growth and development. Now apply this. How can it create issue for these populations that are high at risk. So individual risk factors, let's discuss how these risk factors are linked to elimination problems. Well, we talked about age and growth and development. You know, you have infants, they have no control. There's different things going on. Everything's in that abdomen, you know, they have the big old head and then one little component here and it's all kind of things have to start to grow and work and all that good stuff. So they're at a higher risk of different issues. Children, dietary issues, activity issues, different things. Older adults, we talked about. Pregnancy, we talked about. Neurological impairment. So let's talk about that. If we have a neurological impairment, a stroke, something like that, you see it down there with medical conditions, but it has definitely caused a problem neurologically, brain injury. If that's the case, then we're going to lose control of our bowels and bladder, so we can have different incontinence due to that. Altered mobility. If you can't walk, if you're having trouble walking or you're not able to get around, we're meant to be upright and moving always. If we can. If we can't, we're going to have issues. One, slows down peristalsis. If we're laying down, we're meant to be upright. We can have a lot of issues if we're unable to get to the bathroom due to altered mobility. We have bad legs, arthritis, can't get there fast enough. We can have incontinence and other issues. And what happens with that, guys, unfortunately, with the aged, with incontinence, the concern is they go, I think I'm not going to drink that, or I think I'm going to drink less because I don't want to have to go to the bathroom 50 times while I'm out to lunch with my friends. So we can have different issues, dehydrations then, because of altered mobility. If they're afraid they can't get to the bathroom, they're not going to drink as much or eat as much or do what they need to do. Cognitive impairment. Developmentally, if you have someone who cognitively has not developed to a point of control, or something happens to their cognitive impairment and they're unable to control, so those things happen. But I think of special needs children. You know, they're going to grow, they're going to be adults, but wherever they're locked in, if they are having issues, if they're locked in at a younger age of developmentally of a 3-4-year-old, they could have some actual urinary and bowel issues, and so those things would have to be addressed. Medical conditions such as a stroke, that is an insult to the brain, and they can lose total control of what's going on. Spinal cord injuries, brain injuries. We see those with car accidents, motorcycle accidents, diving accidents. I had a very dear friend's brother who was diving out of a tree in a golf course. He was young, 16, and hit the water wrong, broke his neck, and from the neck down, paralysis due to that. These all can cause problems. Crohn's disease, that's, an inflammatory bowel disease, chronic, and it can cause a lot of issues with bowels. They can have loose stools, they can have impactions, they can just have so much, and we can break Crohn's down later when we talk about diseases. But also renal disease, if we have any issues with our kidneys, if we're having multiple UTIs, prostate enlargement's not on here, that's one to add. Put prostate enlargement for men. That can cause them to dribble when they urinate. They can have problems urinating. They can cause retention, which then they get UTIs. So there's just a lot. One of the things with prostate issues, caffeine is not your friend. Caffeine is a bladder irritant. And by saying that, anybody drinking caffeine will have to go to the bathroom a lot. So if you already have some issues and you are older and drinking caffeine, it can be very irritating to the bladder, and then you feel the need to go all the time. It's almost like UTI symptoms, but it's not a UTI. So let's talk about common diagnostic tests really quickly. There's laboratory tests, the urinalysis, blood urine nitrogen, which is a BUN, and a creatinine. This is going to tell us renal function. We need these labs. These are labs I want my students and everybody else to be honing in on when you're in the clinical setting. Cultures, of course, we can grow out and see what's growing so we can give the correct antibiotic to kill whatever we need to. and occult blood. We want to see, is there actually blood present? Urine, the occult blood we see in stool. So there's ways of testing these things. We have x-rays, CTs, MRIs, of course, ultrasound. Colonoscopies, big. One of the things it's recommended that we have a colonoscopy as we get a little bit older. I'm going to look this up really quickly because it used to be the age of 50. And it's gone down because they're starting to see more and more colon cancers or cancers of the intestinal tract. How old should you be to get a colonoscopy? And it's a good thing to know because it's something that we need to start looking at. So now it has gone down. I thought I was right. It's the age of 45 now. It used to be 50 that they recommended that you have your initial. And then after that, it's so many years if you have no issues or problems. But now they're saying let's go younger, 45. So it's something to go in because polyps and stuff can be removed and hopefully prevent someone from having colon cancer or some type of intestinal, small intestine, whatever, cancers. It's a good thing. Cystoscopy or uroscopy, we're going in and looking at the bladder system. Bladder stress testing, they can fill your bladder. You get an IV and they go ahead and give you a liter of fluid pretty quickly, fillet it to you, and then they measure. They have you hold and urinate, and they measure what's in, what's out, all this stuff. So they start to stress the bladder. They also will put a Foley two-way catheter. It's a two-way catheter. So what they do is they put it in, then they fill the bladder with fluid and really stress the bladder, get it really good and full, and then they will clamp it off, and that's being held up in there, can't go anywhere, and then they wait a certain amount of time. When you can't tolerate it anymore, they'll release that, take the Foley out, and then have you use the restroom, and then they'll see how much. And it's all looking at what you can hold, how long you can hold, those kind of things. So they do definitely lots of different testing, specifically looking at, and bladder scans. And I do want to say this about a bladder scan. So they're on the floor. It's a nursing judgment. If you have a patient that you're concerned about that's having urinary retention, get your bladder scanner, go over. It's not an invasive thing at all. Go ahead, put your gel on, go ahead and scan, and it should give you an estimate of how many milliliters are in the bladder and where. There's usually a cross, and it'll kind of show you where in there. Based on that information, what's going on with your patient or client, what the amount is, call your physician and tell him what's going on. He will then give you an order either to in and out cath that patient or Foley catheter that patient and go from there. So primary prevention for all these things is hydration. We need to be hydrated. You need to be hydrated to have a good pH in your urine and be able to urinate. We need it for our bowels so that we can have good soft bowels that come out, not hard and blocked up. Adequate dietary fiber. We need more fiber, and we'll go a little more into this. My students are doing a whole nutrition thing on fiber. Or fiber should be in a nutrition unit. I'm struggling talking today, sorry. Regular toileting practices. Look at what adequate dietary fiber, what kind of foods have high fiber, things you can eat. I'm going to tell you something I love. I'm gluten intolerant, so it kills me, but every so often I just have to. But I love frosted mini wheats. There's something about them, but that's a high fiber food that you can eat. But there's other vegetables and stuff out there. Regular toileting practices. So that means you get up and go sit on the toilet. Sometimes if you don't take the time, this is a process that has to take. If people rush that, kids are worse for this. They're going to, one, go to the bathroom real fast. If they can't go, they'll just stop and hold on to it and can become constipated that way too. Regular exercise, movement, guys. We're supposed to be eating right, drinking right, working out, exercising, walking, getting around, not being stagnant. Stagnant causes all these problems, right, with the bowel and the bladder, but movement keeps everything moving. Avoidance of environmental contamination. So we just need to be very careful with that because it can cause some issues. So looking at this, clinical management screening, colonoscopy screening, we just talked about that. Age of 45 is the cutoff now, or the beginning age, I should say. Cutoff is life, whenever you finish your life. If you have an issue or a problem, if you are a person that has high risk in the family genetics for colon cancer, or then you can do a colonoscopy. It's something to share with your physician so that you can start to look at preventative medicine, right? We're going to screen in hopes to prevent. Occult blood screening, we want to go ahead and test everything to see if there's occult blood. There should not be blood. There should not be blood in urine or stool, period. No blood. Sometimes people have blood on their tissue and it could be hemorrhoids, and it can seem like a lot of blood because a little blood goes a long way, but really what we're looking at is for blood, occult blood, in the actual fecal matter, or if we see actual blood test for in the urine. Prostate cancer screening, huge, huge. Cough, please, and we'll talk about that a little more in depth when we talk about cancers and stuff. But the thing that I want you to know is we need to screen for that, because if you get a enlarged prostate, it can cause a lot of issues. That BPH, which is benign prostatic hypertrophy, is something that we see with the aged. But prostate cancer, guys, unfortunately affects younger men. So we need to be going to the physician and having these things screened and looked at to hopefully prevent these issues and problems. So there are things we can do. Treatment strategies depend on the underlying condition. So if it's a disease process, we're going to have to look at it, assess it, try to fix it to the best of our ability. There's strategies we can take. There's pharmacotherapy. We can give medications that can help. If you have that urgency to go and you can't hold it, urgent incontinence, we can give medicines for that. I will tell you just personally, I had to have major surgery about 5 years ago, female surgery, and I had bladder repair. I had my sling placed and all that. I have had ever since then issues with my bladder. I always feel like I'm having a UTI, and I couldn't figure it out, and all this. Well, I finally went to a urologist, a PA that was at a urology clinic here in town, and she was phenomenal. And she said, first of all, and we talked about hormones and menopause and what all happens and can cause problems and issues, and we fixed that. And then she talked about diet, and that was the most interesting. It was talking about watching what you eat, watching those things that are irritants, high acid foods, irritating, juices, irritating, alcohol, irritating, all of those things, different things. And so stay away from those things. That's what was said. Stay away from them. The next thing is for the problem I was having to get up. I had urge incontinence, so I would have the urge to go every 5 minutes. So if I drank up in water, soda, whatever, up into the late evening, I was up 4 and 5 times in the night. No rest, make you tired. It's awful. So she said, cut it off. So one of the things you want to know is what's going on and address it per whatever. For me, no drinking after 8 o'clock in the evening and watching those things. And here's the next thing. If you want those things, I just know if I want to eat something that I shouldn't or have a diet soft drink or something, then it's going to irritate my bladder and I'm just going to have to live with those symptoms. But now I know what's going on. So, it's a mind thing too. I can control. So that helps so many issues and problems. Incontinence management. This is something that we do. We have to learn incontinence management. So bowel and bladder training are huge for stroke patients. Or anybody that has had an insult and can't control. What do? The body will produce the fecal matter. So what we can do is get up as soon as we're out of bed, go and put someone on the bathroom, on the toilet, and let them void and defecate. Let them have a bowel movement. It's a training, and they'll get to where they'll just do it at that time frame. But we need to do it on a regular basis. By doing that, hopefully we can help with the incontinence piece. The other part of this incontinence management is we can use things. There's pads out there, there depends out there. The ladies, there are things that look like undies you can pull up and they hold X amount of fluid. So if you have leakage, you're not going to make your clothes wet. You can be active again. And that's what's awesome. Men too. They need to understand those pads are not just for women. If they're having leakage or dribbling and they can't control that, the pad can go to the front so that they can absorb any issues that they're having. When there is a will, there is a way. And so incontinence management is a biggie. Invasive procedures and surgery. So sometimes we have to go in and fix things. For my situation, my bladder, I was having stress incontinence. It was getting worse, getting worse, getting worse. And so when I choreographed, I did a lot of dancing. And so what do you do with dancing? You know, you're pounding on the floor, right? So the more I danced, the more incontinence I would have. So it got to the point I thought, I'm young, I want to have fun. Childbearing is what did it to me. And so I ended up going and having surgery to have that repair and sling placed for the bladder. And it does work. I don't have any more issues with that. I just now feel like I have a UTI all the time. No, but it does work. So it's things to look in at and think about, because there's a lot of problems and issues that people have, but there's a lot of ways we can resolve the issues. I hope this helps. This is the first lecture video, but there will be others to come with a little more detail here and there. So have a good evening and take care.